right. That was great, Dr. Salomons. Thank you so much.
Oh, you're welcome. It was fun. Fun to put
Oh,
together.
I love the interjections where you included, was that your son who came in and asked if you were wearing pants?
Yeah. It's fine. It's kind of typical of how things go these days, isn't it?
Yes, it is. So there is just a couple minute time lag. So people are probably hearing the end of your talk. However, somebody has submitted a question. So I'm going to go ahead and there's a letter. It only shows so much of the question. So I'll just say the full thing.
Okay.
So Robin asks, could you recommend specific studies or articles you would direct surgeons and other doctors to on the importance of validating their patient's pain, exercise in pain response, and education in pain perception? But I'll just show the first half because we know what that last word is, perception. Right?
Yeah. So the second one I probably won't do that well at. Being a psychologist, we don't exercise.
Of course not.
A paper I really like that I am happy to post and send around is by Tate and Chibnall and Kakani. And unfortunately, I can't remember the title, but what I really like about it is that it speaks of this issue of symptom uncertainty and what doctors tend to do when symptoms are uncertain. So when, I had that picture early on where the doctor was saying, oh, you shouldn't have pain. And what tends to happen in that instance is, as I said, they write the pain off like, somehow this must be some product of psychological problems or something like that. And rather than listening and saying, look, because the real answer should be, we just don't understand it yet. I mean, you're allowed to say that as a clinician and a scientist. You're allowed to say, we just don't understand that yet. I believe that you're having pain, but we don't understand it yet. But unfortunately, what tends to happen then is that a lot of clinicians use what this paper by Tate and Chibnall and so on says is that we tend to use heuristics, and many of those heuristics are not good heuristics. So one of the heuristics is if a patient is highly emotional about their pain, then they're probably, they're probably exaggerating. Well, that's not a good heuristic because pain makes people, any of you who live with pain or any of you who know people who live with pain know what that does. And so people like that get undertreated. The study also says that women get undertreated and minorities get undertreated. People of color get undertreated because these heuristics sneak in, right? And so I think that's a really important paper to talk to people about. I would also recommend The Challenge of Pain by Melzack and Wall, because these are, our most respected pain scientists. Unfortunately, both passed now, but they really talk about pain being a subjective experience and the difficulties of objective measures. For some reason, people distrust subjectivity and they think, if we don't have some objective measure, somehow that pain isn't valid. And pain does not have objective measures. I'll say that as boldly as I can. There aren't objective measures of pain. If someone tells you they're in pain, they're in pain. And Melzack and Wall do a very good job of making the case for that in a very erudite way that, any clinician who wants to ignore that or scientist who wants to ignore that does so at their own peril.
And so we have another question here from Adi, and she asks, if you're giving a battery of examinations, you are assuming there won't be any changes in the brain between the examination and the after results. Do you take into consideration the brain flexibility? And so again, because of the character limit, the Y is cut off there, but.
Yeah, absolutely. Yeah. And, I will tell you the problem with this work, we're 2/3 of the way into the study I mentioned. And, from any of this work I've done, it's not just the brain measures, because let's be honest, all of these measures reflect what's going on in the brain. A big problem is reliability, right? That if you take something when I was talking about intrinsic attention to pain, I talked about test, retest reliability. because you want something, if I'm going to answer 7 different ways on 7 different days, that's not characteristic of me. And part of the reason that you put all of these measures together is that you hope that you're able to capture something more reliable. So that's in a way how we take into account the brain flexibility, as in, what mood is somebody in on day, like your measurements will be somewhat different on, if on a day where you're depressed than on a day when you're happy, or on a summer day as opposed to a winter day. There's going to be all sorts of natural variation. And so the part of the reason behind having a large assessment battery is to, one measure corroborates the other, and you get a stronger measure together that is less prone to that kind of variability.
Cool. So we'll just wait just a few more moments to see if any other questions come up, because again, there's a lag and
okay,
somebody might be typing going into the Ethernet.
Yeah.
So I was curious, what made you choose this specific topic for your presentation for the summit?
We're spending a lot of time on individual differences these days, because to be honest, I feel like it might be the biggest sort of unanswered or poorly accounted for question, is that anyone who observes people, if you give a surgery, let's say 100 people have a knee replacement, 20 of them might develop chronic pain afterwards. And in most cases, that is not due to some failure of the surgery or anything. We don't know what it's due to. And, by the time we get way down the road, they've had chronic knee pain then for months and months and months after, and it's starting to bother them. It's starting to it's disrupting their lives. They're not able to work, et cetera, et cetera. It's often too late. And so I feel like understanding those individual differences is really it's a critical question we have to answer if we want to treat people better, because we tend to get, by the time we see a lot of these patients, we're finding it very difficult to make inroads. And I feel like we have to understand vulnerability better from that angle.
Yeah, that's true. So I haven't seen any more questions come in, and I think we'll just give maybe another moment or two just to see. And then
Okay.
I'll just remind the folks who have the Backstage Pass, you did receive the link to log into the Backstage meeting after this presentation. Again, because there's a lag, just give us a few minutes to join. And it looks like we had another question come in. So it's a good thing we're being patient. So let me just bring it into the room. And so Evie asks, does mindfulness training increase trait mindfulness?
That is a really great question. We're actually not certain, because you could kind of guess at it 2 ways. You could say that actually maybe the people who most benefit from mindfulness training are people who already have some trait mindfulness. Okay, so for example, I often think that the reason that academics are so into cognitive behavioral therapy is because it reflects how we think. We overthink everything. We spend our whole day in our own heads, and so we can really relate to cognitive behavioral therapy. I've had patients before where you say, okay, what thought were you having while that was happening? And they look at me like, no thought. I wasn't having a thought. I don't sit here. I don't do that. So, it is possible that the people who will do well with mindfulness are people who already have some proclivity for it, or, but it is also possible that, low mindfulness individuals will be the ones who will benefit most from training. So, to me, it's an empirical question that is very, very worth answering. Because really, towards the end, that's what I was more talking about, is like, how do we steer people towards a treatment that they're likely to benefit from, that they're going to believe in, that they're going to engage in. And, because one of the big predictors of outcomes in psychotherapy studies is the degree to which people buy into the treatment and the degree to which they feel a bond with their therapist. And those come from being prescribed to the right person and the right treatment. So I think that, those are really critical questions.
And we did have a couple more come in. Linda asks, can you address the role of memory in the development of secondary hyperalgesia?
Not specifically from data. I'm very, I think, our study is one of the first to, link cognition and so on to secondary hyperalgesia. But I will say, I'll definitely say I think if I was, to give you my strong hypothesis, it would be that memory is going to play a huge role, because how normally we develop central sensitization is through repeated experience. Okay, if we have repeated experiences of pain, we will quite often become sensitized to that pain. Well, if we have repeated unpleasant events occur to us, we're likely to remember that. So our memories are forming at the same time as our spinal cords is sensitizing, or so on. So it would be impossible for me to imagine that those two are not locked together in some important way, and that, part of this, when we try to help people overcome pain, we are trying to help them build new habits and, overwrite memories. And I can't help but think that if you overwrite memories related to pain, and, that also some of those physiological central nervous system processes will change accordingly. And I think that's what our study kind of hints at. So yes, I think it's an excellent question. And I would, if people know of research specifically in that area that I'm not citing, please do let me know, because it's, I think, super cool.
Cool. And we have another question, which I find is interesting. It's a good question from Matt. And he asked, you cited early work from IASP that you disagreed with. Now that you've done some work with IASP, to your knowledge, have they come back around and revised their stance or changed their verbiage?
I'm glad. So whoever asked that is right on the money here, because that actually was in the text of my, when you give these talks, you're trying not to read right off your text, but so you miss a couple of the details. But yes, absolutely. IASP has come around. I apologize, IASP. Don't send your people out to have me snuffed. IASP has revised their definition, and I will be sharing soon. I taped an interview with Jeff Mogul about the process they went through, which goes through some of this. But if you look at the new IASP definition, which was the paper was published this year in Pain, if you look at the new definition, the actual definition hasn't changed very much at all. So they fought for 2 years over, 3 or 4 words.
One word, I think.
Yeah. But what has changed substantially is the note, the accompanying note. And I think that the new notes are excellent. If I'm putting my cards on the table, I prefer the old definition to the new one, even though they're not that different. I just find the old one a little more usable. The new one's a little clunkier, but the new notes are vastly improved in my, if for nothing else than that, this is usually for psychological reasons, which to me, you lost me right there. So thank you for bringing that up and allowing me to correct myself, or to not have the IASP thugs come to my door.
So I see we should be looking at the notes behind the definition, as opposed to the fact that the definition hasn't changed in its wordage very much.
The notes are much, but first of all, they're much more succinct, but they've, some of the more difficult and challenging stuff has gone. And for those of you who are pain definition nerds, you know that a couple of years ago, we had several different proposed definitions, one of which was from Ken Craig and Amanda Williams, who fought to get social elements into the definition, and those are in the notes now. So they have acknowledged, the important role that social and cognitive factors play. So I think the new notes are very strong.
Cool. And we have time. We have one more question. There may be time for one more if somebody can get it in while he's answering this one. This is from Jim Stark. Are there any clear tools to develop trait mindfulness?
No, I mean, I'm going to qualify that answer because as I said, we don't know yet whether you can change trait mindfulness. Particularly, I mean, the most interesting immediate possibility is that you could change it with a mindfulness intervention. But, you know, the reason we're interested in it to some extent is that it exists prior to any training. So, you know, like you can characterize people by trait mindfulness, you know, regardless of what they've learned or what they know. But in some sense, what this is asking is how stable is that trait? And that's always an issue with, you know, supposed trait characteristics, right? That, well, you know, not all of our traits remain stable. So we talk about trait anxiety. That's very much your level of trait anxiety is going to change if you get a divorce and lose your house. You know, it's not going to remain the same. It's going to be influenced by your state. So I would imagine that you can influence trait mindfulness, but unfortunately, I don't know how yet. So,
all right. Well, this pretty much is the end of the live Q&A. I want to thank everybody who's watching again for attending and coming into the virtual space and giving it your patience to figure things out. I think everyone's figured everything out okay. So those of you with a backstage pass, we will move into the Zoom discussion. And for everybody else, you'll get a break until the next event, which is the meet and greet activity. So I hope you guys will show up. It's free for all attendees, and I have a really fun activity for everyone to do. But you have to show up, find out what